Good evening, everyone. Good morning, good afternoon to all our viewers who have joined us today on the sixth webinar in a series of 6 webinars that we organized since March of this year around the theme Medication Without Harm, which was declared by the World Health Organization. The patient safety series focused on the strategic framework of Global Patient Safety Challenge, which depicts the 4 domains of the challenge, which are patients and the public, healthcare professionals, medicine and systems, and practices of medication. And then the 3 key action areas, namely polypharmacy, high-risk situations, and transitions of care. Today's webinar will focus specifically on polypharmacy and transitions of care. We all know that polypharmacy can be quite disastrous, especially in very vulnerable populations, such as very old people or very young people who are unable to tell what is wrong or if they are experiencing some harm. Also, people with mental health conditions, people who are very sick and are unable to express themselves. And we know that a lot of people, especially who are senior citizens, have comorbidities and therefore have many medicines that they take. They sometimes forget the medicines that they have to take, or they take the wrong medicines. Similarly, in transitions of care, when patients are being handed over from one system to another, in situations where healthcare professionals are extremely stressed, have a lot of patients, very little time, there are chances of errors. So today's discussion will focus on how we can minimize these errors. Joining me today, we have 4 excellent panelists, and I'd like to express my heartfelt gratitude to them for having joined us today. Without much ado, let me first introduce you to our first panelist, who will be joining us from my own country, Dr. Pratibha Nade. She is an MD in pharmacology from Karnataka Institute of Medical Sciences and has worked as head pharmacology and medical advisor at R&D Center Natural Remedies in Bangalore. She is the faculty in KIMS Hubli and currently head of pharmacology at Dr. Chandrama Dayanand Sagar Institute of Medical Sciences and Research Center, Karnataka. She will be speaking, she has many publications to her credit. She will be speaking about medication safety in polypharmacy, how to ensure medication reconciliation practices, strategies to deal with inappropriate polypharmacy, potential key areas to reduce medication-related harm in polypharmacy, and how a patient-centered medication review process could help in ensuring medication safety in polypharmacy. Over to you, Dr. Pratibha.
Thank you, Dr. Ratna Devi and Pear Academy and all associated organizations. Indeed, it's a great movement that you people have started to spread this awareness of medication safety. And I thank you for giving me this opportunity. And without much of background, I would straight away start with my presentation. So as rightly mentioned by Dr. Ratna Devi, WHO indeed in 2017 has taken an initiative to create a lot of awareness about inappropriate prescribing and hazardous prescribing that would result in a lot of medication errors. As rightly put, we are seeing an increase in the lifespan of people, and the society globally is observing a big chunk of elderly population. And as we grow older, there is increase in the comorbidities, the multimorbidities as such they're called, and the prescriptions associated are likely to result in number of, they have a risk. As long as they're appropriately prescribed, the risk reduces. But if it is inappropriate and care is not taken, then definitely we are going to have a lot of issues as far as patient safety is concerned. Next slide, please. I would like to start my presentation with a case scenario. Next slide. Yeah. A female patient aged 68 years suffering from pulmonary tuberculosis came to the outpatient department. She was not educated. She belonged to low socioeconomic condition and lived with her only son who was a welder. There was no improvement in her symptoms of tuberculosis in spite of taking medications for the last 4 weeks. She was on fixed dose combination of 4 anti-tubercular drugs, isoniazid, rifampicin, pyrazinamide, and ethambutol once a day. known diabetic on metformin and glimepiride, known hypertensive on hydrochlorothiazide and enalapril. She was also on multivitamin tablets and protein supplements that she took once a day. So let's see, when you add all these together, the total number of medications come to around 10. And this is not uncommon because globally there is increasing rise, there is increasing trend of diabetes and hypertension, even among the young adults, I should say, more so as the patients get older. So diabetes, hypertension, tuberculosis, and multivitamin. Next slide, please. So when she came with these complaints, she was advised admission. And when her routine random blood sugar was checked, it was 300 milligrams per cent. And of course, all other investigations followed. And she was asked to stop her medications because the physician felt because of her tuberculosis, this sugar was not acceptable and he put her on insulin. There was an improvement of her clinical condition and the patient got discharged after 10 days of admission. On the discharge sheet, however, she was asked to take all her medicines that she was already on at the time of admission, including the oral anti-diabetic medications, as well as the insulin injections. So now we have added one more. At the time of admission, please note she was asked to stop as soon as she was put on insulin, but while discharging, she was asked to continue. On the third day after discharge, she comes back to the hospital. In a semi-conscious state, her random blood sugar was 50 milligrams per cent. She was treated for hypoglycemia and the patient fortunately recovered. So we will discuss the further steps or strategies based on this clinical case scenario. So we have seen, and please observe that there was some error, and we shall see how these errors can be minimized. Next slide, please. So polypharmacy is an emerging challenge in implementing this patient safety programs, and the prevalence is identified to be higher in elderly, 40 to 60% in the elderly, 10 to 20% is in the young population, because obviously the morbidities go on increasing as the age advances. This is global statistics. And when the patient takes more than 5 drugs, then it is called as polypharmacy. And there is high probability of medication errors and medication harm in polypharmacy because every drug has a potential to cause an adverse drug reaction, and there's a medication error with every drug prescribed. So as you increase the number of drugs in any prescription, the chances of medication errors and medication harm increases. More so in the elderly because of multi-morbidities. And it is on the rise, as I said, as the lifespan is increasing. Next slide, please. So medication-related harm in polypharmacy brings about lot many consequences, such as decreased quality of life. The patient has to be on multiple drugs at different times, so he will not be able to participate in social events. He will not be able to do his routine life. So indirectly, it affects his quality of life. Increased possibilities of adverse drug reactions and adverse drug interactions. Inappropriate medication use, because as Dr. Ratna said, patient forgets what he has taken, what he has not taken, the compliance will reduce, therefore the medication errors will reduce, and obviously there will be poor adherence and increased number of hospitalizations and many more. These are some of the consequences of medication, what harm could result in polypharmacy if appropriate precautions are not taken. Next slide, please. So the WHO has come out with a very crisp and effective strategies, which if followed, could result in safety, patient safety, while he is on polypharmacy. So it appears simple, but there's a lot of coordination involved and many people are involved. And however, every step is a reinforcement of the previous one. Now let's see. The first one is appropriate prescribing and risk assessment based on this prescription by the physicians. The next one is medication review. So whatever has been missed out here probably will be picked up when we review this prescription and reassess the patients based on his conditions. I will discuss individually. Then the next one is dispensing, preparation and administration. While the pharmacists and the nurses administer, or the patient's attendants administer the medications, how cautious they need to be, particularly when multiple drugs are being prescribed. Then the emerging one now is communication and patient engagement. How well informed are the patients? And last but not the least, the transcription of the list of medications from the patient's file to the hospital file, and from the hospital file onto the discharge summary, so that nothing is missed and appropriately all the medications are transferred from one file to the other. So therefore, it's a very, very meticulous observed prescriptions and transcriptions and transfer of this information that needs to be undertaken. Next slide, please. An appropriate or rational pharmacy, polypharmacy, that is what we call. WHO has clearly underlined and emphasized on inappropriate and hazardous prescriptions. So then what is appropriate or rational? Rational is one which is based, normally when we say rational therapy, we say right patient, right dose, right frequency, right drug for the right indication. More so it is relevant when we give polypharmacy, because here there are certain gray areas. There's one clear indication, there's one disease and there's one drug, there are standard treatment guidelines and we follow. But we don't have guidelines when there are multiple morbidities. There are no guidelines to describe when a patient of this age with diabetes, with hypertension, or with anxiety, or with asthma. So what are the drugs chosen? There are different classes of drugs. But when you consider the comorbidities, then the choice of the drug varies. The first line of drug varies. So this has to be kept in mind while prescribing. So when the drugs are prescribed with clear therapeutic objectives that are evidence-based, and as I said, the evidence should be with multiple morbidities. So those, or we have to try to generate, or we should be observant. As a physician, I'm talking. Then the therapeutic, when the prescription is in such a way that the therapeutic objectives are being achieved. Being achieved means we must monitor the patients regularly, or we must ask the patients to come for follow-up. Only then we can monitor whether we are able to reach the therapeutic goals or therapeutic objectives. Thirdly, whether adverse drug reactions are minimized in this patient, that has to be observed. And last but not the least, when the patient is motivated to take all the medications as prescribed. So this is another thing. And in fact, in medical education also, we have introduced this concept where the students are taught how to motivate the patient to adhere to their treatment. Next slide, please. So this is the first step. Next slide. Have you changed the, yeah. The next one is, yeah, next slide. The next one is medication review. Medication review refers to further reviewing of this prescription and assess the medications, involve the patient, and finally come out with some recommendations. So when you assess the medications, we need to ask here, the emphasis the WHO has mentioned and all the guidelines state that when there is polypharmacy, you assess the relevance of this medication for that particular patient. It emphasizes on the individualization of therapy. It is not generic. Don't follow the general guidelines. In this patient, when he is on another, let's take the example of my case. This patient was already on insulin and oral anti-diabetic medication. If you look at the treatment for hypertension, he was on thiazide diuretics. So thiazide, hydrochlorothiazide are likely to increase the blood sugar. Was it an appropriate antihypertensive in this patient? As such, he is prone for rise in blood glucose because of tuberculosis. And he has not been responding to the treatment also. There is some morbidity of the condition per se. So we could change. So like that, assess the medication. Does the benefit outweigh the risk? Are there any risks of adverse drug reactions? Does it affect other comorbidities? Will there be any other drug interactions? Is the dose appropriate? And much more important is involve the patient and try to understand, can the patients really take all the medicines you have prescribed? Can he take the injections? Is the frequency appropriate, and can he afford? In my example, what I have given as a case scenario, if we look, she is a patient with low socioeconomic condition and her son goes out. If I prescribe insulin twice a day, will she be able to take that insulin at home? We have to understand that. And will she understand? Now, who has to understand? The son has to understand. Son is not available always by her side. So all these multiple prescriptions, how is she going to adhere to? So considering that, we have to prescribe. And if it is inevitable to prescribe, then engage the attendants and involve him and make it feasible for the attendant to ensure that the patient will adhere to the medication. Based on that, we can give some recommendations, either de-prescribe stop the drug or change the medication, or you increase or decrease the dose, or you can take some other class. As I said, instead of hydrochlorothiazide, we can put beta blockers or the calcium channel blockers or any other class of antihypertensives which are not likely to interfere with her tuberculosis or with her diabetes. Next slide, please. Then the third one, as I discussed already, in the given case scenarios, these are all the medications. And as I discussed, this hydrochlorothiazide can cause a rise in blood glucose. And this could be one of the ADR of hydrochlorothiazide, though it's not very common, but we do have, it is less common. It's not a rare one. Case reports which say hydrochlorothiazide can increase the blood glucose. So there is a scope for the the person who reviews to change this to another class of antihypertensive. Similarly, metformin is likely to bring about renal damage when it is used for in the long run. So one must assess what is her creatinine clearance, what is her hepatic function, and then reassess the role of these and whether the dose of these anti-tubercular drugs is appropriate or not. Next slide, please. Then we come to dispensing and administration. This is a multidisciplinary effort. Dispensing level, there's a pharmacist who has to be very competent enough to once again review the prescriptions and see if there is any kind of overlap or any errors or duplication, and then dispense accordingly and educate the patient from his side. Administration either by the nurse in the hospital or the patient's attendant at home must be careful in administering at the right frequency, the right dose, right route of administration. Next slide, please. Then communication and patient engagement. We have another session which is going to be mainly on communication. However, whatever efforts have been put on prescribing, on review, and on dispensing, all depend on good patient engagement. Good patient communication involves that we train them adequately and we ensure that they understand. Now, in this case, what I have given, the patient may not understand, but the attendant will understand. Building strong relationships so that they adhere to those medications and they believe the doctor or the pharmacist or whoever is the healthcare professional there. And utilization of good resources, the training material that you are using or the people whom you are using for training, all of them should be good communicators and they should be able to build a very good relationship with the patient so that they come regularly. Finally, I would like to make a statement. In fact, we have written a paper. Let us make the patient more responsible in the whole event. Let us not put the blame on the doctors or on any hospital administrators or anybody. Let the patient take the responsibility henceforth. Let us make them understand. If they don't understand, we ask them to come. And if they say doctor did not ask, the patient has to ask. We must tell either of you should ask. If doctor has not told, you ask. Let there be a let it be a combined responsibility of both the healthcare providers as well as the patient. Next slide, please. Last but not the least, transitions of care, that is medication reconciliations. Studies have shown that when the patient moves to the hospital, about 1/5 of his prescribed medications do not find their names in the case file. That means they have been missed out. So that is a very, very important and a serious medication error, grave medication error, because let's say it's a life-saving drug, let's say it is an anti-diabetic or a thyroxine or insulin, so things like that, anything can happen. So that again results, and this could have been prevented, provided there was a meticulous, as I said, transcript this information here. Similarly, from the hospital, when the patient gets discharged, studies have shown that half of the medications that were taken during the hospital have not been mentioned in the discharge summary. Sometimes there is a feeling that whatever has happened in the hospital need not be told in the discharge sheet because no longer they need this treatment. But it is important because any time in the history of patient, they are going to live for another 10, 15 years or 20 years. What happened in the hospital is an important story. It's an important medication history that's likely to prevent further medication errors. And we will understand what had happened to the patient during the hospital, and all the details must be mentioned. Next slide, please. So with that, my key takeaway message is polypharmacy is an important, I should say, a risk for medication hazard, and it can largely compromise patient safety, particularly in the elderly. Good patient-centric approach needs appropriate prescribing, thorough review of these prescriptions, appropriate dispensing and administration, patient engagement, and medication reconciliations. What is important is it is a multidisciplinary approach, and it requires great leadership from the healthcare administrators and commitment from the entire healthcare team as well as the patients themselves. So it is a time for us to raise the awareness, number one, and keep talking to people, improve the communications not only between the physician, patient, physician, nurse, physician, pharmacist. It is among us. There should be very good communication. And I should say, with my experiences on our tuberculosis project, which is multidisciplinary, we are having we are facing a big challenge in this communication, and technology has helped. Because of these WhatsApp groups, we are able to transmit very fine details of every patient through this WhatsApp, and it is helping us a lot, but it is challenging. But with that, I think we should be able to do great service, and we will be able to do, at least our efforts are in the right direction. Next slide. Thank you very much for your patient listening.
Thank you, Dr. Pratibha. That was really very illuminating. Two key messages that I could take away from you. One is coordination, because there are so many people involved, including the patient caregiver and patient's family. And second is communication, which is key because of so many transitions happening, whether patient coming to the hospital or going away from the hospital or taking medicines within their homes and healthcare settings. So thank you for those messages, and we will come back to you with some of the questions that we have already received. Let's move on to our next speaker, and I would like to invite Dr. Sujin, who is the co-founder of Patients for Patient Safety US. She's a patient safety activist, an advocate, and a pharmacist. And can we have her introductory slide, please? She's a board-certified geriatric pharmacist in the United States and a founding member of Patients for Patient Safety US, a group of patient safety activists who have experienced medical harm directly or indirectly, committed to activating US healthcare according to the Global Patient Safety Action Plan 2021-2030 of the World Health Organization. And we hold her in a lot of respect and reverence because of the work that she has already done. And I'm very eager to hear from her what she has to say about health systems' approach to polypharmacy. Over to you, Dr. Sujin.
Thank you very much for your introduction, Dr. Devi. So as she introduced me, my name is Sujin Jan, and I'm a co-founder of Patients for Patient Safety US. Today I'm going to start with my story and lessons learned from my experience, and share about PFPS US, Patients for Patient Safety US, and why organizations like us is essential in creating a meaningful and sustaining change in patient safety. I will also share key strategies to make changes now and in the future, at where you are and beyond. Next slide, please. So this is my father. His name is Gain Lee, and he was a voracious reader and an international businessman. He always stood up for what was right, as you can see in the picture on the left. He was rallying for injustice in South Korea, where he's from. So my father's stage 3 esophageal cancer journey started in the US as a foreigner, and he only had emergency insurance. He experienced many gaps of care, partly because of the cost, cultural, and language barriers, complexity of healthcare in transitions, and fragmented communications on his new diagnosis of type 2 diabetes in between the transitions of care. And not to mention 20 plus medications and 5 times a day glucose monitoring for his sliding scale insulin. And I was a mom. I did not have any healthcare background. I was a wedding videographer. So I had no knowledge of healthcare. And sliding scale means you would check the glucose level at home, and if the level comes out high, you would inject higher dose of insulin. If it's low, you may not, and you would inject lower dose of insulin as directed by the doctor. And we had 2 emergency visits from an insulin overdose because there was lack of education that was provided for us on the intricate relationship of food, insulin, water, and comorbidities. He had esophageal cancer, so obviously he couldn't eat. He had to rely on feeding tubes. So it was not simply, you know, you would, if you get this number, you would inject this number as directed by the doctor. There was a lot more in the background, which I had no idea. And we repeatedly went to ER and came back without education again. So there was a lot of issue of transitions of care and polypharmacy. So we booked our flight to go to South Korea in the hopes of getting more comprehensive and affordable care, not to mention without the communication barriers. And he passed away 1 week before our flight. And this is a tricky irony about the case. He was adherent to the medication regimen. What killed him was what was not provided around the adherence. When there was no education, monitoring, and coaching on how to prevent another adverse event happen again, involving caregiver and the patient, it doesn't communicate that medication adherence is important, or that's going to prevent further deterioration of health. So don't tell patients to blindly be adherent. Please don't. So I want to emphasize on the importance of careful messaging on what we are communicating and the context, especially at system level. Next slide, please. So there are so many what ifs that come to my mind as I share my story. And I wonder how many patients and caregivers never tell their stories or don't know where to turn to, possibly out of fear, anger, sadness, regret, or many communication barriers like language. Or do patients and caregivers even realize medical harm could have been the cause of the loss? In the US, we say medical error is possibly their leading cause of death. But I ask you, is it really? How can we know that if we are not measuring and there is no proper way to report? If I never spoke up, would anyone care or count his case? We often say patients are not numbers to emphasize the humaneness of healthcare. However, I want his case to be a number because he did exist and he matters. Next slide, please. So patient engagement and empowerment is perhaps the most powerful tool to improve patient safety. As you may have seen in the Global Patient Safety Action Plan by WHO. And this is also our belief at PFCS US. Next slide. We have 10 founders, and we all have true stories of medical error and harm to tell. We all have either experienced medical harm ourselves or have lost our loved ones through medical errors. As you can imagine, all of us have had to transform our lives and had to change the deep wounds in our hearts and make a positive difference. Some of us have been working with government, healthcare improvement organizations, even the World Healthcare Organization. And we are born out of the necessity and urgency to improve systemic change that's needed to ensure patient safety in the US and beyond. Next slide, please. And these are our patient safety champions. Most are from the US, but some of them are from other countries. And they also have stories to tell. And these experiences are fuel for our passion for patient safety. Next slide. And these are our strategic partners, which include governmental agencies, nonprofits, and we have other for-profit partners that we haven't listed here. But the list is growing, and the interest in our group's activities is growing, and it's going far beyond the US because patient safety is a global issue. And as Dr. Nadig pointed out, polypharmacy is a growing issue as well. Next slide. So ensuring patient safety is the #1 priority across healthcare organizations is our #1 goal. So that it puts the ground for patients to be partners that create meaningful and lasting change through patient and family engagement. By creating channels for patient safety reporting with proper feedback loops, we ensure transparency in healthcare and safety needed for clinical practice. Next slide. So far, we have been able to partner with our strategic partners and be able to advocate for patients in meaningful ways to spread the effort of patient safety advocacy by co-designing policies, research, and guidelines, creating videos and podcasts, and giving talks in patient safety organizations and efforts in educating clinicians and students. Next slide. So the key is to create space for communication, and it is the key to improve polypharmacy. And we need to do a deep dive to see where we are and co-create paradigm shifts in patient safety with patients. So first, establish the patients and family engagement as a strategic priority. And that means creating something that there was not. We are letting go of what's not working and creating something new with patients as equal partners. Create a channel for feedback loop, foster collaborative environment, and budget for the efforts, and include pharmacists who are medication experts that understand not only drug-to-drug interactions, but many other factors, such as comorbidities, even genes, even socioeconomic factors that come into play affording medications. And there are so many roles that pharmacists can play, like even coaching patients and caregivers. And then develop a national chapter for patient safety at each country where you are, and create a collaborative force of patients and caregivers and advocates that can empower patients by being exemplary and speaking up their experiences. Patients and caregivers have powers to change. They may not realize that. So empowering patients and caregivers is really something that I emphasize a lot. And identify the leaders in healthcare. Many healthcares and policymakers, pharmacists and doctors and nurses, they have chosen the profession for a reason, to help patients. But because of how framework of how we practice healthcare is designed, or maybe there was not designed at all, sometimes we wonder how United States healthcare is, like, how did we get here? We ask that kind of question a lot. And, you know, you need to find the champions within the healthcare leaders who can collaborate with patients. And then also improve medication adherence, not just the adherence, but find the root cause of why patients are getting all these medications. Could there be something that can be described if patients are taking so many medications? And then creating just cultures that can ensure psychological safety when something bad happens. Offer capacity building and resources to patients and families And as I explained in the previous bullet point, patient and caregiver empowerment through education and awareness on monitoring and reporting, and working with community organizations to tackle health equity. And share the best practices and learn from other countries. The countries like England and Norway, they have national reporting agencies on patient safety. And there's a movement in the United States that's developing currently. Next slide. So I am wearing a jacket that I painted with all the names of caregivers, activists, and the lost lives on the back of the jacket that I am wearing. So it's called No Mud, No Lotus, Journey to Zero Harm. As you may know, Lotus goes into painstaking journey of being in the mud. And without the efforts of the advocates, the fruit that we are looking for, or the flower that we're trying to bloom in the air, which that's the zero harm that we're looking for. It's really painstaking journey. It needs a lot of effort, and there will be a lot of barriers. And as Rumi said, wound is a place where light enters you. I truly believe in the power of the lives lost and the efforts that these activists are putting in that can be changed to positive force and create systemic change. Next slide. So I want to give you two questions you can ask in any interaction of healthcare. Is there health and is there care? If the answer is no to any of these two questions, it is certainly time for action to speak up. Remember, my topic was systemic change, but I'm telling you, you have to be the change you like to see in the world first. You have to be able to change your system first, even if it's just you. And I really want to emphasize that you do have power to change. And I appreciate your attention. Thank you so much for inviting me.
Thank you, Dr. Sujin. And thank you for sharing that very powerful personal story, as well as the journey that you have traversed in such a short time for patient safety and creating the patient advocates in US and other parts of the world. Something that really touched me was patients should be partners in co-designing the policies around healthcare so that harm can be minimized. And this is something that governments and policymakers need to really embrace and include, so that more and more patients and families are allowed to speak up when there is harm and there is patient hearing of that harm. So thank you so much for sharing your journey once again. We now move on to our next speaker, which is Clarinda Siricho. She's a science communicator and a patient advocate. You can see her brief bio on the slide. So she describes herself as an emerging patient advocate, though I feel she's already an advocate, with American Migraine Foundation, a Stanford certified design thinker, and a board certified editor in life sciences. She is passionate about educating patients and involving them in healthcare policy making. She has lots of years of experience working with academia, scholarly publishers, etc. Over to you, Clarinda, for your presentation. Please unmute yourself.
Sorry about that. Thanks, Ratna, and thanks, Dr. Pratibha and Dr. Sujin, for a lot of food for thought. it's a pleasure for me to be here today and to be able to talk to you about a topic that's close to my heart. I am a patient with an autoimmune disease and comorbidities, and so patient education is incredibly important to me, and it's really an opportunity to be able to share my thoughts with you today. This is Ben. Ben is an 83-year-old man. He's on routine medication for high cholesterol, hypertension, and diabetes. His daughter Rima is his primary caregiver, and she generally monitors his medication use. Now, one day, Ben travels to another city to stay with his son Ravi for a few days, and Rima is not with him. During this time, Ben accidentally takes 2 doses of his diabetes medication and skips his hypertension medication. Naturally, his glucose levels plummet and he's found unconscious, has to be rushed to the hospital. Ravi has no idea what happened because Ben was absolutely fine just a little while ago. Meet Nina. Nina is a healthy 26-year-old woman. She had a very regular tooth extraction surgery. She was prescribed antibiotics and painkillers or anti-inflammatory, non-steroidal anti-inflammatory drugs for 5 days. On day 3, a completely unrelated consultation, she visited her GP for a urinary tract infection. Didn't think it was relevant to tell the GP about her dental treatment, so the GP prescribed a 7-day course of antibiotics for her UTI. Now, the next day, that's day 4 from the dental surgery, Nina found that her tooth is not aching anymore. She thought, why should I be taking so many medicines? So she just discontinued everything that the dentist prescribed. This puts Nina at risk of developing antibiotic resistance. This is Maya. She is a 38-year-old woman. She fractured her ankle. She had surgery. While she was in a cast, she was experiencing intermittent calf pain. The orthopedic surgeon gave her something. The pain stopped. Maya was happy. What he didn't do was explain to her that deep vein thrombosis, which is what he treated her for, is a serious condition where blood clots can develop typically in the legs. And if they break off and travel through the bloodstream, they can get lodged in the lungs where they can be fatal. 2 months later, again, completely unrelated, Maya has her cast removed. She goes to her gynecologist for some menstrual irregularities. The gynac prescribes oral contraceptives. Maya takes them and starts experiencing calf pain once again. She thinks it's because of the physiotherapy she's doing for her ankle. She doesn't think too much of it, but casually mentions it to her gynecologist at a follow-up visit. And that's when the gynac asks Maya to immediately discontinue the oral contraceptives. Now, for your information, oral contraceptives can trigger DVT, especially in patients who are known to have a history already. So these are all true stories. And what do they teach us? Well, of course, that polypharmacy is often necessary for managing comorbidities. But I think contrary to the established definitions of polypharmacy and the way the industry is viewing it right now, from the patient's perspective, it's not only a concern for more than 5 drugs. It's not only a concern for certain classes of drugs or only for elderly patients or only manifested in emergency settings. And finally, it's definitely not templatized and predictable. How any patient will react to a different combination of drugs is extremely patient-specific. And overall, as you can see from these 3 stories, a lack of patient education can clearly lead to adverse events. So what could have helped Ben? First, better education by the treating physician. He could have sat Ben and Rima down, explained all the medicines that are being prescribed. What do they do? How do they interact? What happens if you miss a dose? What happens if you take a double dose? And how to report such an incident. He could have prescribed Ben a detailed written prescription with notes of caution and could have advised Ben to always carry this while traveling. There could have been better communication during the transition. So Rima could have explained Ben's medication protocol to Ravi before the travel. Ravi could have overseen Ben's medication in Rima's absence. And if Ravi was aware of all this, when even in the emergency situation, he would have been able to share the prescription with the emergency care team in the hospital. What could have helped Nina? First, better education by the dentist. This is a painkiller. This is an antibiotic. If your pain stops, you can stop taking the painkiller, but still continue taking the antibiotic. And it also could have been an opportunity for the dentist to explain antibiotic resistance in simple terms. The GP could have done better history taking and generally better communication. If the GP had asked Nina about any ongoing medication, perhaps it was necessary to ask specifically about dental treatment because patients don't really consider it, part of regular medical treatment. Then the GP would have been able to assess if an additional antibiotic is even necessary and could have reiterated the proper dosage and how and when each of the drugs should be discontinued. What could have helped Maya? Well, the orthopedic surgeon could have explained things better, that what I'm treating you for right now is deep vein thrombosis. Why is it serious potentially? How the treatment works, how other drugs might interact. And more importantly, she should have informed Maya that future doctors need to be alerted about this case, even if it seems irrelevant. The gynac could have done better history taking as well. With a detailed medical history, she would have found out about the orthopedic surgeon's notes. She would have found out about the fracture case, the DVT. She could have talked to the orthopedic surgeon if needed. And she could have also informed Maya that oral contraceptives can trigger DVT and to stay alert and report any incidents of calf pain. So what are patients generally thinking about medication use? You've been a patient, I've been a patient. We've all thought one or more of these things at some point. If a doctor gave it to me before, I can use it again anytime. If I miss my morning dose, I can take 2 at night. If I buy it over the counter, it must be safe. Why should I tell every single doctor my entire medical history? The medicine prescribed is just too expensive. I'll ask the pharmacy for a cheaper alternative. This is particularly relevant in low and middle income countries where I know for a fact in India, many patients can't afford the prescribed treatment and they would seek cheaper alternatives. How can the system do better? Both Dr. Pratibha and Dr. Sujan have covered quite a few of these things. It would need a combination of education, collaboration, regulation, and technology. In terms of education, can medication management become an important component in medical school curriculum, in continuing medical education for doctors? Can there be more widespread patient education about medication use in general, and then more awareness building around common drug interactions and adverse events? Can there be more patient-friendly drug information leaflets and in multiple languages? Coming to collaboration, our systems are designed for a single disease focus, but patients with comorbidities do need a multidisciplinary approach. So can GPs consult with specialists, review therapeutic plans, and consider holistic treatment rather than symptomatic treatment? Can pharmacovigilance, clinical and regulatory teams partner to develop and disseminate clinical guidelines? And finally, can physicians begin to view patients as shared decision makers? In terms of regulations, I think detailed history taking should be mandated on every new consultation. Off-label prescription and sale should be entirely restricted. The pharmacist's role, this came up even in some of the questions that are being posted here. The pharmacist can play a really important role in patient education. Can pharmacists be regulated and equipped to make the difference that they can? And can there be a unified, transparent system for reporting drug-related errors, interactions, adverse events? In terms of products and technology, can there be a more personalized, persistent digital medical record? So something like a medication passport that exists online or that patients can pull up at any consultation they go to. Apps to track medication use, send alerts in case of errors, missed doses, pill dispensers, this is a simple one that ration doses, and clear packaging and labels that prevent confusion between drugs. Thank you.
Thank you, Clarinda. And those three real life cases are so real. They could happen to anybody, anywhere. And they seem so innocuous and so simple, yet they could cause so much of harm to the patient if some of those critical factors had been missed. For example, the DVT one. So we do know that healthcare is very fragmented, and most specialties work in silos. Add to that the whole problem of polypharmacy and people not understanding, having low health literacy. It really becomes an extremely complicated problem. And that is why I think the importance of patient and family engagement and patients understanding why medication is being prescribed, what is the purpose of that particular medication, and what to do in the event they don't feel good or they think they need to report. I think one of the biggest challenges is, even if I know I'm not feeling good or that something is not quite right, there's no institutionalized mechanism for patients to go and report. So as far as pharmacovigilance is concerned, we know doctors, hospitals do report, but there are no metrics where the patient can actually go and report. And Dr. Sujin really mentioned about this, saying there has to be something where the patient can report and these metrics can be measured to understand whether the healthcare systems are really functioning well. So thank you so much for bringing that up. And we move on to our next speaker, Dr. Peter Lushman. He unfortunately couldn't join us in person, but we have his recorded video. He is an MD, MPH, and is a lead faculty quality improvement at the Royal College of Physicians of Ireland. He was the Chief Executive Officer of ISQA and Health Foundation Quality Improvement Fellow at the International Hospital Institute. He has written a lot of books, and we will hear a little more about that in his speech as well. So can we have the video of Dr. Peter, please?
Hello, I'm Peter Lushman. I'm a pediatrician. I work in Ireland now. I was formerly CEO of ISQA, and I'm going to talk about how we can make the discharge process very good for patients, for people who are going home from hospital or being transitioned from one point of care to the other. And when I thought about this topic, I wondered, why is it that we haven't solved it? It seems pretty straightforward, sending someone from one part of the care system to another part. However, this is a very complex problem, and it's got even more complex with COVID. So I'm going to start on what is the key solution, which is about co-producing how we do discharge with the people being discharged. So if we look at this slide, this is the first step that we have to take, and I'm going to refer to this conceptual framework throughout the talk. This comes from a group called Think Personal, Act Local, a community group in the United Kingdom, but the model of the ladder is well known in social care and in participation politically. And it starts at the bottom where most of us in healthcare are. We're doing something to people. So what we do at the discharge process, we educate. This is how you should take the medication. This is when you should do it. This is what you should do. And often it's coercion. And even in our language, we talk about coercion. The patient did not comply. The word comply, think about that. That is coercion. It is not a co-producing something like, or even adhering is the wrong word. So we need to move from this doing to possibly doing for. But doing for is not good enough. Doing for is where we inform people, we consult with them, we ask them what they think, we engage with them, and we still do what we want to do. We do it for them. And that is still holding power. The way we have to go forward is do it with people. So the transition process and the discharge process mustn't be done for people who we call patients. That must be done with them and their families. So we need to co-design with people and co-produce the solution with the people. That is the family, the person we call the patient, and the person we call the healthcare worker, whether it be a nurse or a doctor. And we have to co-produce this across the complexity of primary, secondary, and tertiary care. So when we start to think about it, I mentioned language must change. So we need to start thinking how we speak, what do we say, and what is our language. So for example, often I say, the doctor says to the person, you must take this medicine 3 times a day. How about it saying to the person, what is the best way for you to take your medicine? How would you be able to meet the requirements of the dose? When is it good for you? What will make it better for you? So language is so important. Here's another example. You are being discharged from hospital today. Rather ask the person, are you ready to go home? And how can we help you to go home today? Can you see the change in language? And language reflects our culture. And in patient safety, culture is the king. Culture rules everything. If we do not have the right culture, we will definitely not going on. And if we continue to teach patients as people we do something to rather than we do with, then we are not going to solve this discharge process. So that's the first step, is understanding that we have to co-produce the solution. And for us in healthcare, that is giving up power and sharing power with the people who are receiving care. And that is very difficult to do because we're taught differently when we go to medical school or nursing college. We could also use methods such as teachback. I'm giving you a link to 2 websites here, in which teachback is where we're understanding what does the person who has to be transitioned or take medication know, understand. And it's a communication tool that I really recommend to all. It's so simple, but difficult to do because we have to change the way we think and understand that people understand us differently rather than simply carrying on as it is and saying you must take, and not understanding whether or not the person can comprehend what is required. So teachback, a great method in step 1 of co-production. Step 2 is understanding the facilitators and barriers. And here's a kind of route where a person starts from home, goes to primary care, then goes to secondary care, goes to tertiary care, then goes home, back to primary care, secondary care. And this rotation goes on and on and on continually. But the big problem is people often do not communicate between each other. So there's a breakdown in communication from tertiary care to primary to secondary, etc. So we have to understand that solving this problem goes across all the different domains. Then we have to look at equity. This is from a recent paper on the quintuple aim, because what happened in COVID, we understood that there are problems of equity. The poor, disadvantaged, the people who have not done so well in the past, but even worse. So if we really want to have better outcomes, if we really want to have staff well-being and better experience at lower cost, we have to put equity at the business. And for me, equity is not only equity based on religion, based on economic background, based on where you live. It's across every aspect of our lives. Are we making sure that everyone has an equal chance of good transition and good understanding? And that is essential, and we have to ask that question all the time. Step 4 is making sure there are equal roles for all. So, as you might know, the WHO has a medication challenge right now, and this is their medication without harm key action areas. And as you can see, patients and the public, healthcare professionals have equal responsibility. They are equal here. And that is important because you can't solve the problem one with the other. But as I said earlier, often it is the healthcare professionals telling the patients and the public what to do. I really recommend that you read up about this. In the 10 minutes, I can't go through every area. But as you can see from the patient and public part, there's public awareness and medication literacy. That's where teachback comes in. Patient engagement, I'd say that should be co-production and involving the patient organizations. And I know IOPOS and PAIR are part of this. It's very important that they are leading the way. And only then can you have good medication safety. And the systems and practices of providing medication safety can only succeed then. So let's look in the last minutes or two of what the key messages are. It's very important to understand that this is a complex problem to a simple process, or a simple process to a complex problem. Firstly, empowerment. So we have to empower doctors and nurses to be different, and we have to empower the people we call patients to be able to be equal partners in the transition and discharge process. That's a change of dialogue, a change of the way we talk with people, and a change of the way we think about different things. Secondly, we need to be inclusive. So the discharge process is not discharge from hospital to the community, it's discharge to a wider area, to the family, to the home, to primary care, to the community clinic. So we need to take into account what it is about. It's not about one person being discharged, it's about a wider system. And that system needs to be included in the discharge process. And then we have to think about how we've designed healthcare. And you could see in the WHO framework, there was an area called systems on the bottom left. Now, our systems are not designed for good transition. They work in silos. So primary care is often separate from secondary care, separate from tertiary care, and the home is very far away from that all. So we really need to think about how do we integrate the patient or person journey so that the person does not see the different barriers between the different sections. So that will require a lot of reorganization of work. And finally, we need to simplify. Often the discharge process, the giving medications is very complex. Simplify, make it easy to do the right thing and the right thing easy to do. I hope this gives you some ideas of how we can go forward. We need to think differently. There's more of it in my latest book on Handbook of Patient Safety, and I hope that you can use this to your best advantage. Thank you very much. Hello.
Thank you. Thank you, Dr. Peter. And you raised a very important issue about changing the language and instead of giving instructions, asking the patient whether they are comfortable with the discharge process or with the medication instructions that are being given to them, etc. And also about giving a path so that there is equal relationship between the healthcare providers as well as the patients who are receiving the care. So thank you so much for your presentation. We have a few questions that possibly some of them have been answered by the speakers through their presentations, but there are a couple that we can take. One question is, will it help day-to-day critical reassessment by treatment team for need of continuation of single entity polypharmacy? And maybe Dr. Pratibha, you could answer this question.
Yes, I think so, provided we have a separate team. And again, as some speaker said, I think Clarinda said that we cannot have it by physicians themselves. We need to have a team of clinical pharmacists. We must create positions for clinical pharmacists who can do a wonderful job. Having interacted with pharmacy students myself, I feel they are very competent to, carry forward the prescriptions and do a critical review and come back. My interactions have been also in the pharmacovigilance unit, where the technical associates who are pharmacy people, they come back and they come with very useful suggestions. And I think it is possible, provided their team is separately done under the clinical pharmacologist. And I think it should be done rather, at least for critical care and geriatric people. We must have a system.
Thank you. Thank you, Dr. Pratibha. I think yes. Yeah. Thank you. And I think Dr. Sujin said that digital, can be an enabler. So there's a question on that. With telepharmacy coming into the picture, can some of those aspects of gaps in follow-up for polypharmacy be addressed? Or do you think it actually makes the problem even more complicated? Dr. Sujin, would you like to take this question?
So yes, and I think it can be done, but it needs to be done very carefully. So when it comes to digital health, and we are possibly targeting older adults who may not have resources and access to using these technologies. And there's a learning curve, of course. It needs to be easy to learn and needs to be accessible for the people who are experiencing this type of problem. But I have seen some positive results from some of the companies that I have seen. Some companies, health equity and language is a very passionate topic of mine, and I'm advising one of the companies that has created, that resolves this barrier. So technology like that can be helpful, but it needs to be done very carefully. It can also create digital divide for many people who cannot access the tools. But there's also a field called digital therapeutics that can replace drugs possibly. This involves with a lot of mental and behavioral health that goes into the deeper level than just plain counseling and having a therapist.
Thank you. And I agree. There is one question by Adam about the handbook that Dr. Peter mentioned. So if you can visit our website, you can find the link to that handbook and you can download it if you wish to read that. There's a question by Dr. Rana, how to deal with shortage of clinical pharmacists in each healthcare setting. I think the shortage of human resources in healthcare systems is universal. Not just the doctors, pharmacists, nurses, everyone is in shortage. And the simple answer to this would be that the governments need to invest more in training more appropriate, human resources, as well as do some task shifting so that some of the burden on the doctors is moved to pharmacists and nurses, and these nurses and pharmacists are trained. And also, if you have enough awareness amongst patients and caregivers, they can also take over some of the burden. So I think that would be the short answer to that. There aren't other questions. I'd just like to give 2 minutes to Ankit to present about the patient safety challenge that we are running right now, and we ask everyone to have patience and allow him to present. Meanwhile, I'd like to sincerely thank all our panelists for joining us today. Over to you, Ankit.
Hi, everyone. First of all, I'm thankful all the speakers, panelists to join today for our 6th patient safety webinar. And I'm thankful all the participants who join us today. And let me present you our call to action, Unite for Patient Safety campaign we are running here. So how you can contribute here? It is, yes, you can contribute individual, or you can contribute to your organization also. Here it is the call to action. We invite patient advocates, caregivers, pharmacists, healthcare workers, and all the industry stakeholders to
I think we lost him. So we invite people to take the pledge and to support the statements to address patient safety across the globe. And the form is very simple. You just need to fill a few fields, and it'll allow you to sign the statement and endorse your support to patient safety and patient safety call to action. So thank you so much, everyone, for joining us today. We will have the recorded session shared with you for your thoughts and inputs, and we will also be creating a report out of this. Thank you once again, and wish you all a happy evening or a happy day. Thank you so much.
Thank you.